let's get started. Before we jump in, we're gonna just talk a little bit about us. I'm Danny. I'm a founder of Everydrop app, a mom and lactation educator. Lauren is an awesome IBCLC, pediatrician, nurse practitioner, mom of two. I'm gonna talk a little bit about me, and then I'll hand it over to Lauren to talk about her and to get started. So a little bit about me. I have a 3.5-year-old son. And when I had him, breastfeeding was a challenge for me. It was pretty hard. I had, a lot of mastitis, nipple cracked. I didn't have the support I needed at the time. I didn't have an IBCLC. I didn't have a lactation consultant helping me. I was all over. And I realized that a lot of people around me had similar situation. And I decided to actually study to, learn more about lactation. So I decided to become a lactation educator. And the more I found out that I think people in general, mamas, feel overwhelmed with a lot of information that is out there. And it's super important to have a help with IBCLCs. And I also realized there's not a single sort of place that you can rely and feel confident about information that you get. Like you can get overwhelmed on the internet. So I've spent the last 2 years really studying a lot and putting together an app where, I wish I had as a mom to feel confident that I could go in and see like information that I trusted, put my symptoms and see like how I could improve them. And like based on the age of my baby, also see like, oh, what to expect on that time. So that's how Everydrop came to be. And we just launched 2 months ago. And it's totally free. I want to help other mamas. So if you want to download the app, it's free here. You can use the QR code, or we have a lot of content in Instagram as well. You can follow us on Instagram. But now I'll pass it over to Lauren to talk about her background as well, and to get started on the mistakes.
Amazing. Can everyone hear me okay? Or Danny, can you hear? Okay,
Yes,
good.
I
Awesome.
can hear, yes.
So,
Yeah.
hi guys, my name is Lauren Horowitz. I am a pediatric nurse practitioner and I am a board certified lactation consultant. I have been working at Milk Street Lactation for the past 2.5 years and absolutely adore it. I love helping mamas. I'm also a mom of two. I have a 3.5-year-old boy, actually almost 4, and a 20-month little girl. And with my first, I was practicing as a primary care provider, as you know, at a pediatrician. And I actually did literally everything wrong in the breastfeeding realm with my son. So, they don't teach you that in school, in medical school, in NP school, in PA school. You learn that breastfeeding is good, breast milk is good, and you should do it. But not how to latch. What happens if my baby's slow to gain weight? What happens if what pump size do I use? How do I pump? What settings do I pump? None of that is discussed. It's just, you should breastfeed. So I took it upon myself to become an IBCLC, which is an internationally board certified lactation consultant. And I've been helping mamas feed their babies ever since. I actually had a breast reduction also, so I can bring that to the table in terms of relating to all of the things that moms can go through. We've all been there with mastitis. Hopefully all of you guys will not, because you're going to learn all of the mistakes that might happen and how to avoid them. So anyway, so happy to be here. Thank you for having me, and we'll keep moving on. Okay, so we're going to chat first about breastfeeding. So I'd say the biggest mistake that you can make when you are feeding your baby is having a shallow latch. If your baby is just on the nipple, you will have pain. This is my crochet boob. This hurts. This does not. And breastfeeding should not hurt. Tenderness in the first week or so that is resolving is okay, but it should never hurt. So a shallow latch can not only cause pain, and it can also lead to poor milk transfer. So if we're like this on the breast, which is a great asymmetric latch. The nipple's actually touching nothing, just near the roof of the mouth. The top lip acts as an anchor, and that bottom lip can do what it's supposed, bottom lip, which houses the tongue, is really what's removing the milk from the breast. So your nipple is actually touched by nothing. So a shallow latch is a lot of things that people deal with, but you really should seek help from that IBCLC. Do you want to hop, Danny, to the next? Yeah, perfect. So when we are latching our baby to the breast, I would say the number one thing that I usually see that moms aren't doing, and the first thing I can do to help you fix that latch, is start with your nipple to the baby's nose. So you want to make sure that your nipple is, sorry, I probably can't see that. Your nipple is to the baby's nose, not starting right in line with the mouth. If you can start in line with the mouth, the baby's just going to come on and kind of do a shallow latch like that. If you start with the nipple to the nose, they'll look up at the breast. Their chin will make contact first. And with that big open mouth, you can get them on, with a little bit of help, maybe a hand behind their head, neck, and shoulders really helps them get onto the breast in that right position. So that is the number one thing that I see that a mom can do better when they're just starting out with breastfeeding. Start with your nipple to their nose so they can look up at the breast, chin makes contact first. We wait for that big open mouth and we latch on. And then you also want to make sure that the baby's lips are flanged. They want to be out like a fish, like this, not in. In can hurt you. The difference between in and that lower lip being flanged out makes all the difference in comfort. So if you just stick if you want to make sure that the lip is out, just literally give a little drag on the chin and that lip will be nice and flanged out. All right. So another mistake that we commonly make is thinking that our milk volume is not enough. So, usually we have a new baby. Sometimes they're fussy. Sometimes you're concerned that your breasts are feeling soft or that your volume might look low. Well, there's a lot of things to discuss here. Babies can be fussy for many, many reasons. They're hot, they're cold, they're bored, they're overstimulated, they're overtired. That's a big one. Babies are allowed to be fussy if they're tired. We just want to make sure that they are fully fed first, and then we can kind of rule that out. If you are concerned that your volume looks low, well, are you pumping after a breastfeeding session? Because if you're pumping after a breastfeeding session, you in theory want your volume to be low because that means baby took all of the milk that's in the breast. Go ahead, Danny. So, things that we can do instead to ensure that our baby is getting enough is we want to make sure that we are looking for these 6 things. When I see a mom that is an exclusively breastfeeding mom, and I come with my scale and I do a pre and a post feed weight so we can tell how many milliliters the baby is transferring from the breast, if they can check all 6 of these boxes, I don't care what the baby takes from the breast because we know that baby is a reliable narrator. If we are exclusively breastfeeding, or in general, when you are breastfeeding, if you are hearing audible swallows during the entire feed from both breasts within 30 minutes, that is good sign number 1. Now, why do we say, both breasts, and why do we say within 30 minutes? Well, if you have a brand new baby, the expectation is that they're not going to stay awake for much longer than 30 minutes. And if that's the case, if they're asleep on your breast, then they are not actively feeding, right? So we want to make sure that we are hearing audible swallows. If we're not hearing audible swallows, or if the baby is asleep before 30 minutes, they are not eating, period. So I am very big on saying, hey, mom, check in with your baby. What are they doing at the breast? I don't, someone might say they breastfed beautifully for 60 minutes, but he was just on the breast and sleeping. So in that case, I don't care that he was on the breast for 60 minutes. Was he audibly swallowing for 30 minutes? That's the most important thing. Or was he audibly swallowing for 20 or 25 minutes in those early days? Another thing that we can check off the list is that they're having an adequate diaper output. So, whether they're 4 days old and having 4 or so peas per day, or whether they're 4 weeks old or having 8 peas a day. It really depends on how old they are in terms of what we're looking for diaper output. But that is something that the Everydrop app can keep you in line with, as well as checking with your pediatrician. But it's really making sure that we have that adequate diaper output. After you breastfeed, you want to be feeling your breast soften after a feed. That's a sign of a good milk transfer. We want baby to be feeding every 2 to 3 hours. We are getting that green light from the pediatrician, meaning the baby is gaining about 1 ounce per day. That is not an amount that I want you to be, thinking about, but that is what the pediatrician is looking for when they are going in for their weight checks. And most importantly, we want to see in real time, we see their body language change. So we have the fists tight by the face, and maybe the rooting reflex is still activated. They're in anything that grazes their cheek, they're searching for that breast. Eating the hands, tight fists. Crying is actually a late hunger cue. So we want to make sure that that body language goes from tension, tight, I'm hungry, to those relaxed arms, and arms down, fists open, actually. So if you can check all 6 of these boxes, then you can ensure that your baby is getting enough. If you are checking all of these boxes, but baby feeds every hour, well, for me, I want to make sure that we can try to condense those feeds. My next question would be, if baby's requesting milk every hour, are you getting that green light from the pediatrician? So there's so many things to consider to ensure that you are doing everything right. I think there was a quick question. Do we want to do questions in the end?
I guess we can, since it's relevant, we can answer that.
Yeah. So Jackie,
you just answered it. Yeah.
So when I come to a mama's house, and they are exclusively breastfeeding, if those 6 things, which I ask in my health history when I'm just meeting you guys for the first few minutes of the visit, I'm asking those questions already and getting kind of a baseline of what's going on. If you are telling me that, we're feeding every hour, or the weight gain isn't great, or, maybe all the things are great, but we're not having good diaper output. If you could check every single one of those boxes, the visit goes very differently, right? Because obviously things are going very well if those 6 things can be checked. It's kind of just your check-in. You can return back to this and say, okay, yep. And then you can kind of relax a little bit, because new moms have a lot of anxiety, of course. And one of the biggest things people have anxiety about is, are we feeding our baby enough? So ideally, you want to check every single one of those things for certainty that things are really going well. Cool. So another mistake we see is sometimes confusing cluster feeding with something that's going wrong. So sometimes moms feel that if the baby is having frequent feeds, that the baby's not getting enough. Well, this is a very common thought as a new mom, but rest assured that there's 2 things I want to talk about in terms of cluster feeding. One, your milk supply is highest in the morning. So between the hours of 4 and 9 a.m., you will have the largest volume of milk. Why is this the case? It's because prolactin is your milk making hormone, and that rises after midnight. So a few hours later, you have the largest volume in the milk. Largest volume of milk. As the day progresses, your milk volume actually decreases, but the composition of your milk changes. So you actually have more watery skimmer milk in the morning, and in the evening you have less volume, but higher calorie, higher fat, higher protein actually. So cluster feeding is very common in the evening because baby's not getting maybe enough volume that they want, but nutritionally it is still perfect for your baby. So what they do is they might take a lesser volume because that's what's available in the breast, and they might cluster feed around bedtime. Another reason cluster feeding might happen is because of growth spurts. So at the, in the very beginning, it's a little bit different, but as things progress, this turns to more of a supply and demand system. So if your baby is getting bigger and your baby is hungrier, your baby will come to the breast, cluster feed. The more baby removes from you, the more you will make. And it's actually a good thing. So cluster feeding is sometimes not a bad thing. Although if we don't have a good, nice, deep latch, of course, that's not a good thing. Okay, so kind of what we touched about in the first slide, but another mistake people make is thinking that breastfeeding is supposed to hurt, or it's okay if it hurts. You guys just delivered a baby, whether you had a vaginal birth or a C-section or a natural birth or an epidural or whatever you use for pain control, having a baby, giving birth is very painful. And I often find that people think, well, I just went through all of this. I'll just, grin and bear it. And I often see moms like gritting their teeth or exhaling or like crunching their face or curling their toes. Breastfeeding should not hurt. The most important thing you can do, ask for help in the hospital, ask for help from an IBCLC. It's so important to get latch help. It should not hurt. Now, if you have a beautiful deep latch with the lips flanged and you're being seen by an IBCLC, there are possibly some other things baby is doing inside of their mouth that can be hurting you. This is your sign to go seek some guidance and support from an IBCLC because it should not hurt. If we are hurting the nipple, we're causing inflammation in the breast. If you think of that inflammation in the breast, like stepping on a garden hose, if you step on a garden hose, before where you step, the water doesn't come out of the hose. So if you have any inflammation in that breast at all, that is caused from many different things, but one of which is a painful latch, you can actually inadvertently decrease your output. So pain leads to inflammation. What is mastitis? Inflammation of the breast. So, a shallow latch can be the beginning of eventual mastitis. We want to avoid this. If you are having any pain, seek guidance and support. Okay, another mistake we can commonly see are feeds that are taking too long. So we kind of touched on this also, but babies who are feeding for 45 to 60 minutes and then you got, an hour off and you got to do the whole thing again. It's a crazy cycle. So like I said, young babies, I would say the first 4-ish weeks, they're not expected to stay awake for much longer than 30 minutes at a time. So if we are not, if after 30 minutes, your baby is still audibly swallowing, incredible, do not take them off the breast. But the expectation is such that after 30-ish minutes, they're not going to be as efficient or they might already be asleep. So I want you guys constantly checking in with your breast, checking in with your baby, take a look, listen for those audible swallows. Are they actually feeding? A perfect feed is within 30-ish minutes, which includes both breasts. If a baby is falling asleep really, really easily at the breast, or if a baby is just falling asleep at the breast, they're not removing milk. Simply, they're not removing milk. If they're not audibly swallowing, they're not removing milk. So what you can do to try to increase the efficiency of baby at the breast, if baby is feeding and we're not hearing an audible swallow, I want you to take your hand that's on the side of the breast and compress the breast. This increases milk into their mouth and reminds them, hey, baby, you're here to eat. You're not here to sleep. And that what that results in is them doing a suck, but most importantly, swallow. Swallow, 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 swallow is the most important thing when you're feeding your baby in terms of, are they actually feeding? Just keep in mind, I don't want anyone married to the clock. If the baby's still swallowing at 32 or 33 minutes, incredible. Do not take them off. But after 30-ish minutes is when we expect their efficiency to go down or they're going to fall asleep. All right. So one more. So we also kind of started to touch upon this already, but we just want to make sure that when baby is at the breast, if they're asleep or if they're hanging or if they're suckling is using mom as a passy. The only way we know they are actively feeding is if we can hear audible swallows. It sounds like a little puff of air through their nose, and that's so active feeding is what we want to be looking for. And use those breast compressions like we talked about. And then another thing that is sometimes controversial. So I'm a big proponent of offering both breasts every single feed. If you are a mom that has a lot of milk, and that would be considered an oversupply, there are some moms that are appropriate for one breast. But what that means is if you have a baby that's feeding every 2 to 3 hours, one breast is getting ignored for 4 to 6. So that can in turn decrease your milk supply. We want to make sure that we are removing milk from both breasts every single feed. It might be that baby is on one breast for 10, 12, 15, 20 minutes. We always want to offer that breast. If baby is second breast, if baby is asleep, we wake them up, we burp them, we put them down on their back, we change their diaper, we go through the motions of changing their diaper or fake change their diaper. If you put the baby down on their back and stop cuddling them and they are not done with their feed, they will likely stir. Maybe they even get mad. Cool, you're mad. Come back to the breast. Come to the second breast for dessert. We always offer dessert. Even when I'm really, 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 really full, I will always have a bite of dessert. That is my personal preference. So in the best practice for me, I would say try to offer both breasts every single time. Sometimes baby might be only taking 2/3 or 3/4 of a feed from the first breast if we are only offering one breast. And lastly, this is something that I feel very, very passionately about and could shout it from the rooftops if I could, and let every single mom that has not had their baby or recently had their baby know about. But there is a lot of confusing answers on the internet in terms of mastitis management. So mastitis is simply inflammation of the breast. It is 90+% of the time coming from a place of inflammation and not infection. So often if you have breast pain, redness, possibly a fever, most people call their OB and their OB calls, they don't even ask to see the patient and they just give you antibiotics. That is not the latest and greatest evidence-based practice, according to the Academy of Breastfeeding Medicine protocol number 36, to get nerdy on you guys. The treatment for mastitis, first of all, it's my job as the lactation consultant to figure out what is causing that mastitis. Is it a flange size that's the wrong size, suction settings that are too high, overfull breasts, a shallow latch, a tongue tie? What is it that's causing that mastitis? That's my job. On your end, I want you guys to avoid what's here on the left. I don't even want to say it out loud because I don't want anyone to remember the things you're not supposed to do. But how you do treat mastitis is with high dose ibuprofen. So I'm talking 800 milligrams, not 600. 800 is the max dose. That's 4 Advil pills, the normal Advil ibuprofen that you have in your house, as long as there's no contraindication to taking Advil. Cold, not heat. You might see on the internet heat. Heat is wrong because heat actually increases blood flow. So if you have inflammation anywhere in your body, think a sprained ankle. You would never put heat on your sprained ankle, right? We put cold. So, of course, the first thing we want to do is make sure that we have got a good latch. A proper latch will decrease any risks for mastitis. But think high dose anti-inflammatory. So that's not Tylenol, but it's ibuprofen, Motrin, Advil, all the same thing. Cold. And then other things you can do are lymphatic drainage. You want to get away all that fluid. There's a nice lymph drain by your armpits. You want to do these upward strokes from where the hard area, redness, and uncomfortable discomfort is in the breast. Upward strokes towards the armpit to try to get that away. And then you want to just feed or pump as you normally do. You don't want to excessively pump. And then, of course, seek a IBCLC's help, support for help. Are there any questions on that are in real time that I can just grab on? Okay. Cool.
Yeah. I think so far, no other questions.
Okay, cool.
Yeah. We'll open up for questions at the end too. Cool. So I will talk a little bit about pumping. Let's see what are the mistakes that most people make. So the first one, and it's very common, is to have the wrong flange size. I think that's also related because a lot of the pumps, they come with a default size that's 22 or 24. And that doesn't fit everyone, right? Like we have a whole range of different nipple sizes and areola sizes. So I think most people just go with that, with the default flange. And in general, people actually tend to have smaller sizes than those. So ideally, instead of just going with the default flange, just make sure that you actually measure your nipple diameter. And there's actually a ruler, as you can see here. There's a ruler that you can use to measure your nipple and to make sure, it fits properly on the flange, because if it doesn't fit properly on the flange, you can keep going with it, and it can cause, like Lauren was saying, can cause mastitis, can cause engorgement, and it could be really painful to also pump and make people sometimes not, I mean, obviously pumping is not the most enjoyable thing, but it could make things a little bit worse. So in general, just use the ruler, try to make sure it fits correctly, and then you can order with your pump a different flange size. And for who doesn't know what flange is this outside part that actually fits into your breast, just to be clear, because sometimes the names could not be as clear for everyone who's getting familiar. The other mistake that we see commonly too is pumping for an amount of time that is kind of arbitrary. Like just, setting a session time for 15 minutes and be done. It's not like the best practice. And what could happen here too is that, or like not just for the timing, but until the milk flows too. And instead of doing that, ideally you just want to pump for your volume goals. Because what it could happen is that sometimes we put here a 15-minute example, but there are people that could be pumping for 30 minutes, 40 minutes. It could be overstimulating their breasts, and that again could be causing inflammation on the breast, could be causing other issues as well when over pumping, or doing the opposite too, right? Like pumping less, it's doing a disservice on, if you're relying, for example, exclusively on pumping, and you're pumping less than the ideal for you to actually produce milk, it's gonna affect also your supply. So ideally, you pump to meet your volume goals, and that's gonna depend on the age of your baby. If your baby is a week old, it's gonna require less milk than a baby that's 4 months old. So you have to adjust based on the age of your baby. And Laura, I don't know if you want to add anything here that maybe
Yeah,
I missed.
really quickly. So if you are a mom that's able to pump your volume goal in 7 minutes, that is incredible. Don't tell your friends. But that's the point. If your baby is 2 weeks old, you want to be pumping about 2 to 3 ounces per feed. I don't want you pumping 8 ounces per feed. So that means you turn the pump off after 5 minutes. Amazing. Don't tell your friends. But for a mom with milk volume that's that high, I wouldn't want you pumping for 15 minutes, because that might put you into an oversupply. Oversupply leads to many medical issues for mom and for baby. So even though oversupply sounds like it's a good thing, it really actually can cause some complications.
Yeah, thanks for adding that. And I mean, a quick thing is that it's hard to know what to expect, like how much volume should I expect? So that's in the app, that's in Everydrop, so you can see how much to expect by the age of your baby. Number 3 here is very, very common too. I think a lot of moms, when they start pumping, they go into the suction mode super high just to get more milk, and just think like, oh, I'm gonna put in the highest suction possible and just keep going. But that again, it could be a problem because it could hurt your nipples. It could be inflaming your ducts. It could be really, really painful as well if you do that, instead of just sticking to like a lower suction setting and be a little bit more constant with that. I think it's also something a little bit tricky, to find. You have to find like the right balance for you, but usually sticking to like a lower section, it's better for you in general. Another mistake that we see too, and it's very often, is a lot of people have wearable pump as the primary pump. which could be a disservice for moms in general, because those pumps, they are not as efficient as the electric pumps, which are usually the wearable pumps, or they're made for you to be more on the go and to use more in situations that you have to be outside, and they don't have such a strength that can help you to take so much milk as the double electric pump. They can be more efficient, and because they do have a little bit more strength, they're closer to a hospital grade pump, but you can have it at home. And so that those are the more optimal pump for you to use in a daily basis. But obviously, if you need to like go outside and use a wearable pump, you can use that as I would say, as a secondary pump. And before I move to the bottle feeding, I see Laura made a couple comments. I don't know if you want to voice it out, those comments.
I was kind of answering people's questions along as we went, so I didn't distract you. But no, I think we're good. I mean, the only thing I really wrote was that the average nipple size I see is between 15 and 19 millimeters. Everyone, the Spectra, which is my favorite pump, comes with a 24 and a 28. I've never personally met a mom that's a 24 millimeter in my entire career. So that's telling. I mean, I've seen as small as an 11. I'm a 15 and a 17. They're sisters, not twins. So make sure if you are measuring them without the support of an IBCLC that you measure both.
Awesome. Cool. Now let's talk about bottle feeding. Okay, common mistake here too is getting a fast flow nipple or narrow shape bottle, which, I mean, as a new mom, how do you even know that this is a thing? You know, I think a lot of the times we follow what our friends are recommending. Oh, I love this bottle. This other bottle is great. And, you know, everyone has a different situation with their baby, and their baby is different. But sometimes the bottle is causing your baby to, for example, to overflow the baby with milk. So that's the issue with a fast flow nipple or narrow shape nipple. When we say narrow, it means like, well, I'll show you the other bottle here so you guys can compare. It's narrow because it has a very deep, has a very like narrow pointy area, and then it goes very wide in the base, as opposed to the slow flow nipple. It's more of a triangle shape, and there's actually like a way that you can evaluate your bottle by doing the triangle test. If your bottle actually fits into a triangle, it's great, because a slow flow nipple, it supports better your baby, because it's the shape of it really mimics the breast. While if you look at this one on the left, it doesn't really follow your breast shape, because the nipple is really more out here on the bottom. So that's the main difference. You want to avoid that the baby is getting a lot of milk with a fast flow nipple, and avoid as well the shape, because it's not as close to the shape of your breast. So try to stick to a bottle that it has the shape of your breast, and make sure that the flow is not as fast too, which on those type of nipples it shouldn't be. And I know that Lauren has thoughts on that, on the bottles too. Lots of thoughts on the bottles, if you want to share your thoughts as well.
Yeah, the goal is just to have a deep latch on the breast and the bottle, period. So a bottle like the Philips Avon on the left, which literally every single one of my moms always, always, always has, because marketing is a bitch, excuse me. They market that it's very like a breast. I've never seen a breast that looks like that in my entire career either. The point is deep latch on the breast, deep latch in the bottle. So a bottle like the bottle on the right encourages that. I linked actually the link for an even flow balance bottle, and they do also come in glass. Now, if any mom, because I know a lot of you are expecting, if any moms already have the Philips Avent in glass, That's awesome. Use those bottles. The even flow nipples are actually compatible to use with the Philips Avent system. Um, just make sure you're using the right nipple if you're using the Philips Avent bottle. Does that make sense?
Yep, it
Cool.
does. Yep. Awesome. So another thing too is the wrong amount. So especially when the babies are born, you know, their stomachs are so small, like day one, and their stomach is the size of blueberry. And then increases to be like a walnut. So it's very, very little that they need to breastfeed. But sometimes if you need it, there are situations that sometimes you need to breastfeed, you know, besides your breast. People tend to think like, oh, my baby needs to feed a lot. So, and have like the full bottle or like a higher amount that they should have. So when the babies are small, the newborns, especially in the beginning, try to stick to like 1 to 2 ounces of the, you know, either if you're pumping or if you're using formula, try to stick to like a smaller amount and go by the cues of the baby. And it increases over time, right? So in the beginning, like the first days, they probably need like 15 milligrams of milk, which is very, very few, like could be just a spoon. But then as the days go by and they go like to 2 weeks, 3 weeks, then you can start to increase to like a couple ounces. And yeah, and like when they get bigger, obviously like you increase more and more and more the volume.
Do we want to touch really quickly on feeding cues?
Yeah, we can. You want to talk about those?
Yep, sure. So the crying actually is a late feeding cue. If we want to get in front of it, we want to make sure that you're seeing those hands up at the fists up at the face. If you don't feed me, I'm going to punch you. That's what that means. Rooting, so anything that strokes the cheek, they're going to turn towards the whatever it is to find the breast. Lip smacking, tongue thrusting, eating the hands is probably the most obvious one. And then again, crying is a late hunger cue. So if you see those eating the hands or the rooting, they're hungry. I had a client once that said, they're just showing me hunger cues all day long. And I'm thinking, well, they're hungry. Got to feed them. Got to feed them more. So they're showing you hunger cues. Trust them.
And remember in the beginning too, you're gonna feed a lot, right? So like between 8 to 12 times a day, every 2 to 3 hours, you'll probably be breastfeeding in the first 2 months. So just to give a range, so for you to expect that there will be a lot of feeds. Try to go fast because we have 5 minutes. Number 3 is that also not doing pace bottle feeding. You will see here, like that's the most common position where the baby is laying down and you have a bottle all the way turned to the baby. So that could also, that together with the fast flow nipple could actually make your baby drink more milk that's supposed to, and it doesn't mimic the flow of the breast and the position that you usually offers your breast to the baby. So try to practice pace feeding, which is a little bit more horizontal. It's a little bit more gentle. The milk is not fast flowing all vertically. And the milk goes in less frequency as well, less volume in that horizontal position. So as you see in this photo here, the mom is holding the baby's head, and the milk is a little bit more horizontal, so it doesn't flow as fast, the milk. And then last but not least, not knowing when to supplement with formula. So a common mistake here is assuming that you have low supply and then you have to go with formula. And very common too is that people forget sometimes that you know, you have to pump to support your milk supply too, because if you just offer the formula and you don't pump, then your supply is going to decrease. So what we recommend to do here in this case is, yes, formula is needed in many situations. For example, if your baby is a preemie, which is babies born before 35 weeks old, 37 weeks old, if they have jaundice, or if you have very severe nipple pain, formula can be recommended on those cases. And try to pump to support on those times. So then you can also, at the same time that you're using formula, which could be temporary, you can build your own breast milk supply, and then support your baby, and then replace the formula later on when you're like, let's say, get better with your nipple, or when your baby gets older and then you want to transition from bottle to breast, or use your breast milk and replace with formula too. That could be another way of going this about. And I know Laura has thoughts on that as well, if you want to share anything here.
Yeah, you don't have to necessarily supplement with formula. If your pediatrician dubs that the weight loss has been not good enough, or you've had too much weight loss since birth, you don't have to supplement with formula. You have to supplement with something. The goal is to ensure that baby is getting X mLs or ounces per feed, depends on how old they are. And they need to get something. It doesn't have to be formula. If you want to start pumping to protect your supply when baby's getting a bottle, you can absolutely supplement with pumped breast milk. So I know there's sometimes some confusion about that. I'm happy to clarify further, but I think actually it's time for questions after this. So if anyone has any further questions, we would be happy to answer for you. So yeah, just opening it up to you guys.
You can put the questions on the chat or just ask yourselves to.
Can they, I don't know if they can unmute themselves, but.
If you cannot unmute, just put the questions on the chat and we can answer those questions.
Since a lot of moms are still pregnant, one thing that I can recommend to you guys is that after 37 weeks, you can hand express some colostrum. This is called harvesting colostrum. So that is basically your insurance policy. It's extra colostrum. It's not taking away from the colostrum after birth. It's your insurance policy of colostrum, which is that liquid gold that you can bring with you to the hospital. Use if your baby has high bilirubin, is a little extra sleepy, isn't latching well, you can give him or her that colostrum that you took before you were born, before the baby was born. How do we share feeding with our partner, breastfeeding, and also pumping? Okay, so quickly to answer that one. So if you, ideally, if partner is giving a bottle, you are pumping, period. There's a lot of recommendations out there that say not to pump until 4 to 6 weeks until breastfeeding is established. Well, that recommendation is out there because the baby can't put you into oversupply, but a pump can. So my view is if you want partner's help, or you need a break, or whatever the situation is, 100% pump to replace that feed. If your baby is 2 weeks old and taking 2¼ ounces, great. So you pump 2¼ 2.5, whatever it is that you can pump at that time that baby is getting a bottle. Let's see.
Yeah, there's a question related to the hand expressing colostrum, saying, Sabrina is asking, does harvesting always cause contractions?
Yes, because, and I always want my clients to understand the why, because there's so much like mishmash on the internet. I'm science medical based. Yes, it can cause contractions. And the why is because oxytocin is the milk ejection reflex hormone. And that is the hormone that is what's facilitating labor. It doesn't always cause contractions. And that's why the recommendation is to wait till 37, just in case it does. But for me, it did often. So I would do it for 5 or so minutes. I might have a contraction or two. Those are called Braxton Hicks practice contractions. My body was not actually ready to be in labor or give birth. So I would stop after 5 minutes. But your body will not go into labor unless your body is ready for labor. So that being said, I'm a lactation consultant. You better believe that every single day I hand express my colostrum after 37 weeks. I was still induced post dates after my due date. And my body still wasn't ready. So, it doesn't do anything unless your body's actually ready for labor. Of course. Yeah.
Another question here too. I heard that starting to pump with the first weeks after birth can mess up your supply, cause oversupply, increase risk of mastitis. Your thoughts on that?
Yeah, totally. So it absolutely could. It could, because you might be a mom that has a lot of milk right off the bat. And if you accidentally remove 4 or 5 ounces when your baby is 4 days old and taking about 45 ml, so an ounce and a half, that is going to put you into oversupply. So my rule is, if you need to pump, if you want to pump, you pump for volume, not for time. If you're lucky, that might be 5 minutes. If you're me with a breast reduction, it might be 30. But the goal is to pump for volume, not time. The recommendation to not pump for the first few weeks is it's a little bit crazy to me, because what about the moms whose babies go right to the NICU? If you're separated from your baby and baby can't remove milk from the breast, you got to start pumping, if you want to, of course. But that's kind of one of those global recommendations that's totally specific to each mom and each situation.
Yeah, and that's actually what happened with me. My baby became like his weight dropped over like 10%. And I went crazy on pumping, and then had mastitis and all those things. And we look at the volume and it seems really low, and you think like, oh, it's not enough. But actually, for the baby that's a week old, you don't need that much milk. So just watch out for those things. And that's a great question.
If anyone, since there's still so many pregnant mommies, I would say my number one tip for new moms is booking a prenatal visit. And this can all be done virtually. There is just so much to learn and myths to debunk, and kind of just eases your anxiety to get you set up on the right foot. That would be the number one thing that I can recommend to new moms. And we actually take insurance. So if any mom out there has United Healthcare or Aetna, it's actually fully covered. But it's a gift that keeps on giving, since you don't have to pay for that. And honestly, every mom should have the same coverage. But if anyone has further questions, we are here for you. Good luck to everyone who is still pregnant and feeding their babies. And I'm happy to stay on and answer a few more questions if there's anything that anyone else is still wondering.
Yeah, same. Thanks for everyone for coming.
Yeah, it was our pleasure to bring you the information, and we'll talk to you soon. Good luck, everybody.
Yeah, thank you. Thank you so much. And I'll check if the presentation is going to be available, and if you
I'm
can
pretty
share.
positive it is.
Yeah, and then we will share via email probably then. Thank you, everyone. Good luck. Oh, I see one more question.
Yes. I mean, I can only speak to me because I can't speak to everyone else, because it's actually dependent on the provider. But we take HSA cards, and then we provide you with a super bill that then you can submit to your insurance if you want to try and get some reimbursement. Yay. Yay for lactation consultants being covered with insurance.
Yes. And I know it's not related, but Everydrop is free. So if you need information that's reliable, it's free. So
amazing.
Awesome. So thanks everyone again for joining. We'll be sharing the information. I hope everyone has a good time breastfeeding as well, and getting started on the feeding journey. Right, Lauren?
Yeah, 100%. And if it's a challenge, reach out. 100% here for you, here for all my mommies. So it's not easy, and it's not always intuitive. So
exactly. Yeah, very good point. We are here to help. Thank you so much, everyone.
take care.
Take care. Bye.